So definitely we know that hyperglycemia is an indicator of poor clinical outcome and the mortality in hospitalized patients in non-critical care condition. So we have to follow a consistent blood glucose target from admission to discharge. Definitely the morbidity and the mortality is being reduced. So the current intervention with sliding scale insulin is being currently is discouraged nowadays, and the recommendation is scheduled subcutaneous insulin therapy, which is being advocated, which is done by using basal bolus and correctional insulin regime, which will be I'll be talking upon in after a few slides. So the current regime which has to be followed is the scheduled subcutaneous insulin therapy for managing non-critical care in patients. So this presentation will provide you a basis for the management of hyperglycemia in the non-critical care setup. Next slide, please. So the next slide, I mean, you skipped some few slides. So the diagnosis of hyperglycemia in non-ICU setting is, so any amount of blood 140 milligrams is termed in-hospital hyperglycemia. Whether the patient has already a known diabetic or not a known diabetic, whenever the blood sugar is more than 140 milligrams, we can label them as in-hospital hyperglycemia. And for patients with or without history, we have to monitor the blood sugar, especially with the glucometer, that is point of care testing with the glucometer, at least 24 to 48 hours. And also HbA1c should also be done for diagnosing the patient if already patient is not a known diabetic or the HbA1c is not done in the previous 3 months. So in hospital hyperglycemia is any amount of blood sugar more than 140 milligrams. So definitely we know that hyperglycemia with or previously known diabetes is associated with the greater risk of death. So these are the data which are saying that, so the total inpatient mortality, the ICU mortality and the non-ICU mortality are all increased in both already known diabetic or new onset hyperglycemia whenever the patient is being admitted. And what are the causes for the in-hospital, the increased mortality in the in-hospital hyperglycemia? So it's mainly the hemodynamic insult, which is produced by the illness and also the hyperglycemia, electrolyte losses, the oxidative stress, the myocardial injury produced by the hyperglycemic oxidative stress, hypercoagulable states due to the hyperosmolar states due to hyperglycemia, altered immunity, decreased wound healing, and increased pro-inflammatory conditions, and decreased endothelial functions. All these factors put together is caused by increased hyperglycemia, that is increased glucose as well as increased fatty acids. So this profoundly impact the outcome of the patient, whether it's going to be critical or non. So we have to monitor. So how are we going to monitor the hyperglycemia? So for insulin treated patients, so the recommendation is, if we are able to cope up or the CGM is available, real-time glucose monitoring is available, definitely we can go with that. But then and there we have to do confirmatory bedside point of care blood glucosing is done with the glucometer. So CGM, if it is available, the facility is available, definitely we can proceed with CGM. Definitely the adjustment in the insulin dosing will be better than point of care blood glucose testing. Whenever CGM is not available, so monitoring blood glucose levels can be continued with glucometer, that is CBG with glucometer. So it's a better one. What we are commonly using is the CBG with glucometer. But with the newer advent of CGM, we can have a continuous glucose monitoring if it is available. And the timing of the testing will be whenever the patient is on meals, routine diet, the ideal blood sugar monitoring should be each meal, before each meal and at bedtime. And whenever the patient is on rice tube or parental nutrition or NPO, so the blood sugar monitoring should be done every 4 to 6 hours. So what is the target, glycemic target to be achieved in when patient being admitted in the non-critical care? So the various recommendations are there, and the current recommendations is actually pre-meal blood glucose of less than 140 milligrams and random blood sugar of less than 180 milligrams. This is the target we have to try to achieve. And the ideal target will be on average between 140 to 180 milligrams. This target can be lowered down in few subset of patients whenever the patient is able to sustained glycemic control without hypoglycemia whenever the patient is very stable, and we can quite monitor, frequently monitor for hypoglycemia. We can have a lower threshold between 100 or 110 to 140, or whenever the patient is having terminal in the terminal illness or high risk for hypoglycemia, the target can be raised to 200 milligrams. So the ideal target will be 140 to 180. Depending upon the individual patient, we can lower down or increase the target. So how are we going to approach the hyperglycemia management? How are we going to approach is, so depending upon the blood sugar. So if the blood sugar is below 200, so we can categorize the type 2 diabetes with the blood sugar level. We can categorize them into mild, moderate, and severe hyperglycemia. Whenever the blood sugar is less than 200 and previously the patient was using less than 2 antidiabetic agents, or we are using the insulin as a newly, the insulin naive patients. So we are starting insulin as that of IP, and at that time of IP alone, they can be labeled as mild hyperglycemia. For this group of patients, we can start with low dose basal insulin, or we can also even continue oral antidiabetic agents whenever the patients are stable. And we can give additional correction doses of insulin with rapid acting or short acting insulins before each meal. So these kind of group of patients will be having mild hyperglycemia. They may be requiring a low dose basal insulin along with correctional doses of insulin. May also be continued with OAD what they are taking along with the correctional dose of insulin that can be given. Whenever the blood sugar is between 200 to 300 with the moderate hyperglycemia, or the patient already on multiple antidiabetic agents, more than 2 agents, or the insulin requirement, already the patient was on insulin and the requirement of insulin was less than 0.6 units per kg per day. So for these group of patients, we have to have only insulin alone. No options of OAD is in this group of patients. We can utilize OAD in this group of patients with correction doses may be needed. And usually the dose required for the basal insulin initiation is 0.2 to 0.3 units per kg per day, and correctional doses with either rapid acting insulin or short acting insulin every 6 hourly. So this, how are you going to calculate the correction doses? I will be coming up with the future. Having severe hyperglycemia, that is blood sugar of more than 300 milligrams, consistent blood sugar of more than 300 milligrams. With previously the patient might be using multiple antidiabetic agents, or the insulin requirement previously the patient insulin requirement was more than 0.6 units per kg per day. We have to fix this regime, that is basal bolus regime is most ideal. So here the basal insulin as well as bolus insulin, and the starting individual regimes will be, I will be dealing with this regime in the incoming slides. Whenever the patient is not critically ill, so the ideal will be to start them on continuous insulin infusion, whether it can be a surgical or medical indication. So the ideal will be you have to start with a continuous insulin infusion, or whenever the patient is having DKA or HHS or mild to moderate DKA, so it will be better to go for subcutaneous insulin infusion. And in due course, this continuous insulin infusion can be transitioned to subcutaneous insulin infusion in the moderate hyperglycemic category. Next slide, please. Coming to the non-insulin medication, apart from insulin in the non-critical care. So insulin therapy is recommended for optimal glycemic control in non-critically ill patients. But in patients with mild hyperglycemia, we can have our selected stable patients. We can achieve, we can add on OAD along with the basal insulins, or we can add on prandial insulins with OAD. Certain drugs can be advocated, especially DPP-4 inhibitors. They are very safe as an add-on therapy with along with insulin for glycemic management during the stay. Similarly, metformin can be given whenever insulin alone is not sufficient to control to have a good glycemic control. You can have metformin in addition to insulin whenever it is the contraindication is not there. So that is whenever the eGFR is more than 30. And regarding whenever the patient is having heart failure and the eGFR is more than 20 and there is no contraindication, SGLT2 inhibitors can also be added in selected stable patients alone. Otherwise, insulin therapy is the goal and is the mode of correcting hyperglycemia. And which regime already I have told. For mild, you can go with either a basal insulin with the addition of correction insulin. With the moderate hyperglycemia, you can go with basal with correctional insulin. And with severe hyperglycemia, it's better to go with basal bolus regime. And the conventionally used sliding scale insulin should be discontinued as a sole therapy, because this sliding scale insulin, what we mean is actually reactional insulin dosage. So on seeing the blood sugar, you are just going to administer insulin. That's called sliding scale insulin. So with this kind of insulin regime, then definitely the patient will have or will not have a good uniform glycemic control, and there will be flexibility will be there. The patient is at risk of developing hyper as well as hypoglycemia. So sliding scale insulin is nowadays not recommended. So what we recommend is the scheduled subcutaneous basal bolus regime along with correctional bolus. And whenever the patient is hemodynamically unstable or the blood sugar is persistently high, you have to go with IV insulin infusion, similar to that of treating critical care patients. So basal bolus therapy is the ideal regime, and this constitutes three components. One is a basal component, that's a basal insulin or bolus component, and correction insulin. So this basal component is by giving basal insulins, that there can be either an NPH or long-acting insulin. NPH can be administered once or twice daily. Long-acting insulin such as glargine can be administered once or twice, whereas degludec and detemir can be administered once daily. This correction insulin is administered together with the usual dose of bolus insulin for insulin with higher blood glucose levels. Bolus insulin is by the rapid acting or short acting insulin, which is advocated before each pre-meal, and correction insulin is done along with, it should be added with the bolus insulin to have a good control. For patients controlled on premix insulin prior to admission, the same regime can be continued whenever the patient is stable and the glycemic control is good. Once the glucose control is stabilized, selected patients can be shifted to premix insulin therapy also. Even subcutaneous thrice daily insulin can be converted to premix insulin also. Whenever the patient is nilpil oral or the patient is in right strip feeding, so we have to initiate the basal insulin. For whenever the patient is in right strip feeding, it's better to start with basal insulin with the total daily dose calculation, and addition of correctional insulin, whether rapid acting insulin or short acting insulin, with the 4th hourly or 6th hourly blood sugar. Next slide. Starting insulin regime we can now see in a step-by-step manner. Next slide. So for basal bolus regime, I will just tell the step-by-step initiation. You have to first calculate the total daily dose, TDD, that's the total daily dose of insulin. This can be done with the various units per kg calculation. So ideally for normal or overweight, it will be roughly around 0.4 to 0.5 unit per kg. Whenever the patient seems to be very underweight or elderly, fragile, with a significant renal failure, or the patient is on hemodialysis, we can go by a lesser dose, that is 0.2 to 0.3 units per kg. Or whenever the patient is having obese or insulin resistant, the patient is on steroids, severe infections, post-CABG, or the patient is on total parenteral nutrition, we can have a higher insulin dose, that is a total daily requirement maybe 0.6 units per kg per day. Next slide. The next step will be, next slide, we have to split the total daily dose into 50-50 or 40-60. So this 50% of the total daily dose can be taken for long-acting basal insulins, and that is either glargine, degludec or NPH. Another 50%, that's a remainder 50 up to 60% can be taken as a prandial component, that is either a short-acting insulin or rapid acting analogs. So this total daily dose can be split up into two components, 50-50 or 40-60. 40% will be an NPH or long-acting analog, basal insulin. 60% will be a short-acting or prandial insulins. And step 3 will be, step 4 will be, step 3 will be the bolus insulin is divided equally between 3 meals. So the 60% can be divided into 3 components, and it can be divided equally between 3 major meals. And step 4B, you have to measure the blood glucose by the point of care, that is a glucometer, that is 3 pre-meal and 1 bedtime, and you have to adjust the insulin dose, the prandial insulin dose, according to the blood sugar value. And also you have to measure the insulin sensitivity. So this insulin sensitive, so certain group of individuals are more sensitive to insulin sensitive, especially elderly, not an oral diet, renal impairment. For these kind of patients, we can start with this level of blood glucose, level of insulin. And for insulin resistant individuals, you have to little more high. So now the blood sugar is between 140 to 180. So for insulin sensitive individuals, you have to give 2 units in addition to the divided doses what we have already calculated. between 180 to 224 units, 220 to 260, like that. We can have a gradual increment of the insulin sensitive individuals. The insulin can be incremented. Similarly, for insulin resistant individuals, you have to increase, give a little more higher dose. So yet another way of adding this extra insulin apart from the bolus insulin will be, we have to calculate the correctional bolus dose. Correctional bolus insulin, that is adding correctional insulin along with the already calculated bolus dose. Next slide. So this can be done by a simple formula. This is a 1700. This is 1700 divided by the total daily insulin required. For example, if the patient is requirement is total daily requirement is 50 units, then 7,700 divided by 50, which is equal to 30, meaning 1 unit of insulin will lower 30 milligrams of blood sugar. So this correctional factor can be a correctional dose of insulin can be derived with this formula: current blood sugar minus target blood glucose by correctional factor. For example, if the current blood sugar is 250 and the target blood glucose what we need is 100, so the correctional factor is 30, then 250 minus 300 by 250 minus 100 by 30, which is equal to 5 units. So you have to add 5 units along with the bolus prandial insulin to each meal. So depending upon the blood sugar value, we can calculate this correctional bolus insulin. If the blood sugar is so high, so according to the 1 unit will cover 30 units. So is roughly about 250. That means the correction will be around 5 units. So you have to add this units to the we have already calculated the bolus dose. So next one will be basal insulin titration. So this can be titrated with the fasting blood sugar and pre-dinner blood sugar value. If the FBGs or the pre-dinner is more than 180 milligram, we can increase the basal dose by 20% every day. And if it is between 140 to 180, we can increase to 10% every day. And if it is below, if it is the hypoglycemic range less than 70, and the insulin dose should be reduced by 20%. So by adjusting the blood sugar value in the fasting and pre-dinner value, by knowing the fasting and pre-dinner value, we can adjust the dose of basal insulin. So now we can, so we have adjusted the bolus, we have just calculated the basal dose and the bolus dose, as well as we have just added upon the correctional dose, and adjustment of the basal dose also we have just seen. So just we can have a small common scenario in our patient setup. Here is a 65-year-old male with a 10 years diabetic with HbA1c at 10.8, the blood sugar of 300. His weight is roughly about 90 kg, and he's on OAD, metformin and sitagliptin in the maximum dose. And he's now being admitted with pneumonia, and for fever management he's been admitted. He also has moderate renal impairment. So with this clinical scenario, so this patient comes under, so definitely the patient requirement will be around 0.6 units per kg per day. So the requirement will be, so keeping 90 kg in mind, so 90 into 0.8, because being overweight and the patient is also being put on steroids, 0.8 into body weight, roughly about 72 units. So this 40-60 division, we can have this 40% as a basal, that is roughly 30 units of basal insulin, that is degludec we can plan, and 60% to be bolus dose, roughly about 42 units divided by 3, that is roughly 40 units of bolus dose of aspart can be given 3 times 30 units of degludec. Insulin can be calculated depending upon the correctional factor and that formula 1700 divided by the total daily dose. So with that way, we can add, next slide, we can add the extra dose of bolus dose, and the patient who is on insulin, who is on steroids, this is the recommended prescription suggested insulin. Whenever the patient is having methylprednisolone, it's better to give NPH is the current recommendation, and the peak glycemic effect occurs at about 4 to 6 hours after ingestion. And whenever the patient is DEXA, the glycemic effect will be 8 to 10 hours, and it's better to go with NPH twice daily without rapid acting insulin analog. Whenever the patient is on prednisolone, the better you give rapid acting or short acting insulin or NPH once daily. So when the steroids are tapered, you have to also, don't forget that you have to decrease the dose of insulin. So whenever the steroids are tapered by 50%, the insulin dose should be reduced by 25%. So here our patient is still not taking oral feed. So we have decided to start on right strip feeding. So as already told, the total calculation, daily insulin dose calculation is roughly around 32 units. And this, along with this 32 units, can be split up into twice daily NPH, that is 16 units twice daily. Along with that, you have to add correctional insulin scale whenever the blood sugar should be done either 6th hourly for rapid acting insulin or 8th hourly for short acting insulin. And you have to, according to the blood sugar value, we can add prandial insulin along with the major right strip feeding. So the base will be, the basal insulin can be divided, given as twice daily, along with the correctional insulin can be given either 6th hourly or 8th hourly, depending upon the insulin we select. So the patient improved well and planning for discharge, what are the treatment advice? So for all patients with good glycemic control of HbA1c less than 7%, restart the same oral antidiabetic insulin therapy. For moderate glycemic control, whenever the HbA1c is between 7 to 9 prior to hospital admission, oral antidiabetics along with the basal insulin is more advocated. And the patient already had a poor glycemic control, it is better to continue basal bolus insulin even after discharge. And patient education should be given, and the formal discharge instructions on the doses and the methods and timing of insulin administration should be given for the patient. What about the insulin pump? So whenever already the patient is using insulin pump therapy, so the current recommendation is you can continue insulin pump therapy rather than continuous basal bolus therapy. But whenever there is expertise is not accessible, we can then go for scheduled, we can stop the insulin pump and we can go for scheduled subcutaneous basal bolus therapy. So coming to the regarding carbohydrate counting, whenever the patient is a known type 1 diabetes or for insulin treated type 2 diabetes, there's a concept called carbohydrate counting. So this I will just tell in next slide. So for non-insulin treated type 2 diabetes, the using carbohydrate counting is not recommended. This is the current recommendation. So it can be used, carbohydrate counting can be used for especially for type 1 diabetes and insulin treated type 2 diabetes. It's up to the option to decide whether to use or not, depending on the patient and the doctor's decision. But generally, we don't use for non-insulin treated type 2 diabetic patients. So for this carbohydrate counting, that's a rule called 500 rule. This is 500 or 450 divided by the total daily dose for rapid acting and regular insulin. So suppose the total daily dose is 50 units, then the insulin to carbohydrate ratio is 500 divided by 50, that is 10. That means 10 grams of carbohydrate will be covered by 1 unit of bolus insulin. So suppose the patient who is an inpatient is a type 1 diabetes already on basal bolus regime, he is on insulin, regular insulin 8 TDS and an NPH of 12 units at the night. So suppose the patient still having a good, not achieving a good glycemic control even after correctional dose. So we have to adjust the bolus insulin with the carbohydrate ratio. Suppose we can even calculate the carbohydrate intake the patient is going to take the preprandial. Accordingly, we can calculate this ICR, that is the insulin carbohydrate ratio, and we can add on the bolus insulin, so that will have a small more edge to have a good glycemic control for especially for type 1 patients already, and also for the patients already on previously on insulin needed type 2 diabetic patients. So to conclude, so diabetes in non-critical care is associated with adverse outcomes and increased mortality. The treatment with basal bolus and correctional regime is the choice, and it should be in a scheduled scheduled subcutaneous insulin, and it should not be, you should not advocate sliding scale insulin. And all insulins are similar in terms of glucose lowering effect, but the risk of hypoglycemia is less with analogs compared to human insulins. Thank you for patient caring. Next slide.
Thank you, sir. Wonderful presentation, sir.